Hello, everyone. Welcome to the Lab to Cloud, the digital transformation of healthcare file chat. I will start a brief introduction of myself. My name is Pengyi Shi. I'm an associate professor at Purdue University. I got a PhD degree from industrial engineering, and I've been using AI, machine learning, and mathematical models to help improve hospital operations. So I will pass to the next speaker, Dr. Rong Li.
Hi, everybody. Ron Lee. I'm a physician and clinical faculty at Stanford. I practice internal medicine in the hospital and the medical director for digital health. So primarily working on implementing different technologies to enable new care models for our health system. Great to be here.
Next, Mithun.
Yep, thank you, Dr. Pengyi. Pleasure to be here. My name is Mithun Panda. I'm an associate partner at Bain & Company. So I work in consulting side. Have done large-scale data and AI transformations across various industries besides healthcare, and happy to provide some insights here.
Okay, and our last speaker is Dr. Teng Fei.
Hello, my name is Teng Fei Ma. I'm currently an assistant professor in Stanford University. My main research is about machine learning and using machine learning for clinical informatics. For example, using machine learning for like diagnosis or prediction of the mortality. So it's my great pleasure to be here. Thank you.
Okay, so according to our host suggestion, we will start for the targeted question. So I'm posting the one that is targeted for me right now on the chat. So it's asking about so based on my experience of building predictive analytics for healthcare, how do I see these tools improving access and affordability in healthcare, especially social determinants of health and the push for equitable care? So I think this is a great perspective. So as a lot of our research do, we use mathematical models and operations research tools, and we care about both the system efficiency and also fairness in resource allocation. So in particular, in some of my recent research, we talk about mobilizing workforce, such as nurses, to staff hospitals that struggle with a workforce challenge. And those hospitals tend to be the one that in rural areas where they have difficulty in retaining nurses. So what we do is to actually set up this internal travel nursing program. So instead of using the very expensive traditional travel nurse, we actually mobilize the resources nurse in the same system and allow them to work, say, in a remote hospital for 1 day or 2 days. So in this case, they cover the care in the remote hospitals, but also the remote hospital do not need to hire a sort of a contract nurse or travel nurse. So in this sense, I believe like using advanced analytical tools in the proper way can definitely improve both the efficiency and accessibility especially for people in the rural areas. Okay, so I will now move to the second target question for Dr. Rong. So I will post it here as well on the chat. So Dr. Rong Li, building on your focus on the delivery science of new technology, in what ways can we leverage implementation science to ensure AI tools are effectively scaled across diverse healthcare systems, particularly where market-driven forces may conflict with the goal of universal access?
Great. Well, thank you so much, Dr. Shi, and really love to also comment on the program that you described, because this is actually somewhat similar, or at least similar in concept to something that we're developing here at Stanford. Going back to maybe the broader concept of how do we achieve universal access, which I would take it as achieving the best healthcare for as many people or everyone if possible. if that is overall our goal, in some ways, it may not necessarily conflict with market forces in the sense that if the demand for healthcare is there, then we're going to have to basically address that demand with something that could be efficiently delivered. And I think that's agnostic to whatever market you're in. Like that is ultimately the goal of all of us here in healthcare. So I'm really struck by Dr. Shi's example where you're basically being creative with a care model, right? Like you're not relying on a traditional care model of having to make sure nurses are employed by a certain organization and then dealing with those constraints. What you're doing instead is you're creating a new product, right? You're creating a new product that leverages the nursing resource more efficiently. It will increase access. It would decrease the operational costs for any individual health system. And thereby you're leveraging market forces, but you're also increasing access. So I think that is how we all think about this. Like, how do we leverage the market to incentivize different groups to be more creative, to be more efficient in leveraging these scarce resources? So going to how then technology, AI, data, how do we leverage these capabilities to make these products possible? I mean, that is in some ways what I call product development, right? Like when I use the term delivery science, like I construct it as in an academic, through an academic lens, I think of it as a science. But if you want to talk about, let's say, someone in industry, to them it's product development. I mean, I would frame it for them as how do we develop the best product that leverages nursing care, and maybe a feature of that product is an AI powered, I think in your case, Dr. Shi, you're using some kind of predictive analytics to predict when and where those nurses are needed.
Exactly.
In our case, we're building a program that leverages remote nursing as well. And it's a new type of care model that allows patients to be at home. But we need to be smart about how we select those patients efficiently, and that's where there's a lot of opportunity to use AI. So I guess to summarize, I think of it less as how do we implement technology. It's more about how do we create the best product so that we can leverage the market to maximize access to high quality care for as many people as possible. And then how do we use these types of tools to enable the features of such a product? And I think we're hearing some of these examples already.
Perfect. And Dr. Ronglin, and maybe we will go finish all the 4 target questions and come back to some more discussion and conversation among the speakers. So the next question is for Mithun, and the question I also posted here. Recognizing your distinction as one of North America's leading data consultants, what are the key challenges and opportunities you see in deploying AI and big data analytics at scale in healthcare? Again, especially regarding cost management and interoperability.
Great, thank you. So basically, we are discussing about 2 key dimensions. One is the cost side of it, and then interoperability. Definitely, there are a lot of key dimensions, but I would stick to these 2 in particular. Look, one of the biggest challenges in AI and analytics transformations, from my experience leading large-scale healthcare transformation, is the inability to clearly convey business value to key stakeholders, this is really the business value part is very important here. And this is where you get your buy-in and support from your leadership team. Now, if you want to go on a journey on AI and large-scale transformations program, it requires upfront investment, not only in terms of the infrastructure, but also in terms of the tooling and technology, your workforce planning, your capability building, etc., so on and so forth. Now, if you do not have a proper roadmap, ensuring each of the milestones is creating incremental business value for the business, leadership will question the ROI of AI initiatives. This is one of the biggest challenges that I have seen. Again, there are mitigations. You have to get the buy-in from the stakeholders. You have to bring the right stakeholders or users from the beginning of your AI transformation journey, because the feedback loop is very, very essential. This is one of the challenges. Second, you mentioned about the interoperability. Look, if we look at the spectrum of the healthcare data domains, it's fragmented, right? It's fragmented across various systems. You have EHR systems, wearable devices, legacy database systems, data warehouses, etc. Now, if you want to build an analytic solutions, you have to have the right integration in place and interoperability among various systems. I can share an example. Back in 2022 and early 2023, I was leading a leading one of the largest hospital chains in USA. We are building a EHR agnostic digital front door, and that client had more than 150 hospitals. It also had senior living facilities and pharmaceutical side as well. The client had an inorganic growth. That means it has grown inorganically through merger and acquisition. So now you see where the challenge comes from. So you would see instances of various EHR instances of Cerner and Epic, Allscript, right? So because there were kind of heterogeneous EHR instances, and we had inconsistent data systems, in data formats, inconsistent data standards, data quality issues, data integration issues, and it was all HL7 V2 format. And HL7 V2 standard allows for custom implementation. So that means each hospitals can modify the data structure, again making your interoperability very hard, right? Also, few hospitals had different version of HL7 V2, 2.x, 2.2, or 2.3, doesn't matter. We had to create an EHR agnostic, irrespective of the EHR. We had to create a digital front door which will integrate with any kind of EHR systems, converting HL7 V2 to FHIR standard with a common data model, right? Standardizing each of the FHIR resources and creating a single source of truth for key data domains such as SCPs, healthcare practitioner, or the locations. So this way we'll be able to enable the analytics. So that is something that it was a 15 months case, and I was part of for that healthcare. And this is what the interoperability becomes very important. I would just like to expand to one more dimension, which is a regulatory barrier, right? As we know, healthcare, like banking, it's a very highly regulated industry, and it really becomes hard or difficult to balance AI innovations and regulations, I would say, and particularly when it comes to privacy and security aspect of it, of patient data, right? So making sure that when we are designing our systems, AI systems, we must look at the privacy first architecture, so that at least it will be compliant. Now, in terms of the opportunities, look, definitely. I see very few opportunities in terms of this landscape. One is the adoption of FHIR standard, which is already happening, definitely. And as we adopt more into the FHIR standard, it will enable seamless interoperability, so that data can be exchanged electronically and real time. Advent of generative AI has definitely made us more innovations, creating innovative AI powered products, such as AI augmented decision support for clinicians. So that is something. AI in drug discovery, which is a really big part which is happening. Hyper personalizations through AI enabled solutions. Telehealth, AI for remote patient monitoring. So these are the kind of opportunities that definitely we see. And as Professor Ron mentioned, right, definitely, it is all comes about to accessibility, affordability, efficiency, and patient care. So this AI kind of solutions and the opportunity that we have, the disruption is continuing to happen. And this is where we are living in terms of the opportunities and in terms of the challenges as well. This is all I would say.
Fantastic. And we'll come back to that question, because I do realize a lot of even in the same hospital, a lot of their systems don't talk to each other. Yeah. So I'll move on to the next, the last question for Dr. Tongfei Ma. So the question is, based on your work in applying learning to medical time series data, how do you envision these methods reshaping real-time patient monitoring and early detection of critical conditions? And what are the key challenges, be they technical, regulatory, or clinical, must be addressed to scale this kind of innovations?
Yeah, that's a great question. My background is more about computer science and machine learning. So I know little about system, and also I didn't have like much experience about the real applications. So it's just my 2 cents. I think one major challenge is, especially from the technical perspective, is not machine learning. It's more about biomedical sensors, or how do you collect the data. So that's the bottleneck to like reshape the real-time monitoring. Because if you don't have a very good sensor to get the real-time data, yeah, you have no ways to monitor the patients or do predictions. Of course, the data quality is also very important, but that also relies largely on the sensors, not the machine learning algorithms. But of course, there are also some technical challenges for machine learning. Of course, the heterogeneity, I think Ms. already mentioned that, like for different systems, even in the same system, like different types of the patients, they may have quite different signals. And even for the same sensor, like at different environments, maybe the values will also be changing a lot. So, like, how do you develop a unified machine learning model to, model all these kind of time series data across like different data types, across different hospitals, across different patients? That's very challenging. And another type of challenge is not only about technical aspects, but also about the policies or the clinician. So, for example, if you have a machine learning system and you can do very good predictions on your benchmark data, but how do you convince the clinicians to use them? And how do you convince the patients to trust your prediction results? That's also a challenge, because most of the machine learning algorithms are just like black boxes. So you only have the input and output, but you cannot explain, okay, why I have this kind of output. That's also what I'm trying to address from the technical perspective. So, for example, we can extract some like shaped patterns. We can tell the clinicians, okay, because the time series contain this kind of shapes, because the signal suddenly goes up or suddenly goes down, or slowly like moves forward stably like that. Based on this kind of different patterns, it can show you, okay, different types of the patients will have different patterns. That's why these patients potentially have this kind of disease like that. So it's just the beginning phase, but I think that's also a big challenge, not only from the technical perspective, but also from the clinician perspective. Yeah, and also the policy, like even the clinician trust you, like will the hospital accept your algorithm, accept your system? That's also a big challenge. Yeah.
Thank you. Thank you. So I guess I saw a posted question from the probably some live audience. So Elena asked for, as automation and AI grow more integral to clinical workflows, how can healthcare institutions retain or upskill clinicians to collaborate effectively with this new technology? So I think this is a really great question, because some of our past discussion actually touched on essentially this AI literacy among users, right? So maybe we can also talk about it, because I think this is something I have been struggling as well. As I mentioned just now, I have developed some of this AI tools for nurse staffing, and I recently visited a hospital and realized everyone is actually doing nurse staffing on paper. So there's probably a gap on that. So I would like to hear how each speaker think about that. Maybe sure. Dr. Lee, you're a physician. Maybe you know all the AI machine learning. How do you see like the different AI literacy among different roles in the hospital?
Mm-hmm. I think that's such a great question. I can definitely speak to that. I think the single event that probably had the biggest impact in upscaling clinicians and having clinicians, or your, let's say, not even clinicians, staff and clinicians, your average worker in a health system be familiar with AI, was probably the release of ChatGPT. I would say it's like, I would think of it pre-ChatGPT, post-ChatGPT, because the world is very different. Pre-ChatGPT, people didn't really care about AI that much. I mean, there are definitely those of us who are interested. I mean, people at Stanford, they're not all, but many physicians were certainly aware of AI. But for the most part, it just wasn't really taken that seriously, because the folks who developed AI, the people who used AI, maybe their individual research partnerships, typically belong to a fairly exclusive group whereas most people just wanted to see their patients and go home. So most people didn't have time to even think about AI. Now, post ChatGPT, all of a sudden AI became something that was very accessible. People understood what it was. Most people don't care about machine learning models, predictive errors, whatever, right? But people understand chat. They understand chatting with a robot. So all of that became much more relatable. And then most importantly, with the release of ChatGPT, you started seeing clinician staff from all over the country starting to experiment themselves. I remember pretty quickly after the release of ChatGPT, you had doctors writing on blogs showing how they were using ChatGPT to write prior authorization letters and all sorts of things that were annoying in their workflow. So there was like a pretty significant moment, I think, then when your average physician, clinician, staff member just started to feel empowered to apply this capability to their workflow. I think the lesson here is, in order for us to upskill clinicians, upskill staff, so much of it, I think, has to be bottoms up. It has to be kind of a grassroots, organic approach. One, because and this is not even just for physicians, I think for any industry, if you're talking about using AI for any industry, I think just approaching it with the humility, acknowledging that we just really don't know that much about their daily lives, their workflows, what really bothers them. I mean, we might know a little bit based on what we read, but that really accounts for 0.1% of probably the diversity of cases and situations they find themselves in. So I think what's often much more effective is you make available these technologies in a safe way, of course. And then you have people feel empowered to experiment with them, to build themselves, and then have it be relatable to what they do on in their daily life. And then you'll start to see actually a pretty significant increase in adoption, not because we're doing it to them, but because it's more of a pull mechanism, because they're asking for it and they're incorporating it into individual applications. So I actually run a group at Stanford called the Stanford Emerging Applications Lab, SEAL for short. And what we actually do is we partner with clinicians to build applications, not necessarily AI applications. We're very careful actually to not say they're AI, because it's really just any application that helps workflow. So for example, we just released an application that helps our nutritionists visualize different nutrition data so that they could dose tube feeds and other forms of artificial nutrition. So to your point, Dr. Shi, you're surprised. A lot of these workflows are still done with pen and paper. So before they use a combination of Excel, pen and paper, just because it's the most convenient thing to do at the time, the electronic health record did not solve for it. So they came to us, we co-developed a very simple application for them that pulls data using FHIR and other standards from our electronic health record. We created visualizations, again, no AI, just simple visualizations, calculations. Immediately got adopted very quickly to the point where now I think more than 90% of cases that they use, or cases of calculating artificial nutrition, is now used by our application versus the standard. And they're showing that they're very satisfied with it. They love the application. We've now used it on more than 1,000 patients. So that's an opportunity now for us to layer on AI, right? Because they don't care about using AI. They just care about calculating their tube feeds more quickly. But you can imagine there are all sorts of opportunities to layer on some prediction models or whatever, even generative models, to make the process easier. And then all of a sudden you got an AI adoption for nutritionists. So I think I can name so many more examples, but that's one specific example of how we think about this grassroots bottoms up approach.
I love this term, grassroots. I agree. Indeed, if you want to increase the adoption, has to convince the end user and the ones who's actually going to use the tool day to day in their workflow. So as we're discussing this question, I think Dr. Lee already touched some discussion along. Maybe the second question is talking about from the current system to AI platform related to adoption. While we scale this up, letting people use it, how do we navigate through data privacy, security, especially if we want to sort of lay a new sort of development on their existing ones, especially healthcare is a very regulated setting. So perhaps Mithan, you could chip in some of the idea, because you talk about irregulatory constraints before.
Absolutely. Look, first of all, we need to design our systems in such a way that it's a privacy first. And the approach is shift left. So what is shift left approach is your privacy and security is embedded from the very beginning of your architecture. So you cannot just wait till the end and you apply the various constructs of security and privacy. No, it has to come from the beginning. Now, when you look at the privacy and the data privacy, to comply the lot of regulations such as HIPAA or GDPR, there are so many FDA regulations. Look, important is that we have a lot of mechanisms in terms of the technology, such as an encryption, so the pseudonymizations. There are a lot of, you can do a data encryption in transit or in motion. There are a lot of techniques there, which you must be embedding into your architecture standard. Similarly, the security side, privacy and security, such as role-based access control, MFA. There are a lot of techniques that you can leverage that in terms of the privacy and security. Now, at the advent of generative AI, we also need to make sure that we are creating AI systems, where we are not exposing the PII data, right? Which is really important. So there are a lot of safeguards that we can do in terms of the architecture, where we'll eliminate we'll eliminate the risk of exposing the kind of PII data. So definitely we have built a lot of systems, not just limited to healthcare, where we'll have PII data, we'll have the data privacy and security concerns. But one important thing that I wanted to share from my experience is you need to bring the legal team, compliance team, security office team from the beginning of your transformation journey. If you are building a really large scale AI applications on the solutions, you need to bring them beginning. You need to tell them upfront that, look, this is the use case we are trying to solve. These are some data sets we would be needing. Any concerns you have. So get the buy-in from the very beginning of the journey, and then you leverage your right tooling and the technology methodologies to make sure that the privacy and securities are not disrupted. This is all I would say. Yeah.
Thank you. So again, I guess teamwork is definitely needed to bring everyone on top of the regulatory and making sure we're not leaking data, especially in this generative AI time. So some of the also the related question during our discussion just now is again how to gain users' trust, right? How to build a trust. I think Dr. Ma has mentioned some of this also earlier on, and here's a related question posed by the audience. So how can we balance between the clinical methods with rapidly evolving AI tools without losing the trust of providers and patients? So probably Dr. Ma can chip in more on this question.
Okay, yeah, that's a major issue of clinical systems. So how to balance the AI tools and the trust of the providers and patients. I think so. First of all, I believe that with more and more powerful AI tools, actually providers and patients have like more and more trust in the techniques. So, for example, Dr. Lee already mentioned that before ChatGPT, machine learning, they didn't care about machine learning at all. But after we have so powerful ChatGPT, they started to accept this kind of tools to upscale, the clinicians. So that's a very good example, and I think. Of course, from the AI side, we also need to make our tools more and more not only powerful to get better accuracy, but also more and more interpretable and visualizable. So I just mentioned the interpretability. For example, we can generate some patterns to explain why we get this kind of results. But another way is also to make your results more visualizable. For example, you have a lot of patients, then you can maybe just extract similar patients and visualize their history in a dashboard also, so the clinicians can also check the facts easier from their side. So yeah, that's my thought.
I can also just add maybe a point here, which is the experience of the providers and the patients should drive the incorporation of the tools in a way that would maintain trust. So what I mean is, so actually, if you think about ChatGPT as an interface, GPT 3.5 and GPT 4.0 or O1, they're completely different models, right? I mean, the methods are actually very different. Most people probably, I mean, they know it's a difference, but they're not actually thinking about it as that different. I mean, I'm sure people in this audience are very aware, and I'm sure we're very aware of how different they are. But for like your average person using ChatGPT, they're just using ChatGPT. So what I mean is, in that case, you have two very different AI tools that rapidly evolved. But I don't know if necessarily people lost a ton of trust, or maybe, or I don't know if most people were that disoriented with ChatGPT. I think for them it was just, oh, it's like a slightly better version, right? I think that's, if you ask your average person, they probably would just tell you, oh, it just got a little better. So I think in healthcare it's similar. I mean, if you have a provider or a patient using, let's say, a digital front door product, they're not going to care about what AI tool is used or a methodology is used to power it, but they want to make sure that the experience is somewhat consistent. And that's what I would recommend, is like, if you think about the experience first, just make sure you design an experience and a product that people like, that people trust. And of course, you're going to use different tools to make the process better. But as long as that experience is something that providers and the users trust, you probably don't have to worry too much about which backend methodology they'll trust more. I think it goes back to the principles of product development. I think with AI, definitely you want to maintain trust by not having data breaches. Certainly, explainability to the extent that it impacts the experience is important. But I would just focus very much on the experience, the user experience itself.
Mm-hmm, mm-hmm.
Yeah, I would
Fully
just like
agree.
to.
So a lot of this engagement. So just to summarize, I heard a lot of things along the line. You need an iterative sort of design process and engaging the person who's actually going to use it to increase the trust. Sorry, so Meetan, please go ahead.
No, just a quick point, just to complement around what he's just said. Look, when we build a kind of large scale transformation cases, first we look at the patient journey or kind of user experience side of it, right? And this is when you establish the feedback loop. You iterate, making sure that they can see the value out of it once we complete the use case or once we complete the transformation. So definitely that is key, and that also establishes the trust. When they see the value, they will get it, they will use it. Now, if we don't bring them along the journey from the beginning, then you can build a fancy user interface, but there will not be any user. So there's no point of the use case. So this is what I would say.
Yeah. So I guess the related comment I recently got from talking to people in healthcare is that they also see a huge sort of difference in the acceptance of AI machine learning tool among people, of a different age in the hospital, because you have like really senior people who definitely want to do everything on paper pencil and has a lot of skepticism to all these newer tools. There's also like a much younger generation, say like newly hired nurse or staff, who are much easily adapted to new technology. So this might relate to one of the question I see here posted by Emily. A lot of the C-suites in hospitals are more senior people. They may have more resistance or, different opinion about AI. And also as, people in the leadership role, they do need to juggle through a lot of financial constraints, reimbursement models, and, also like there are a lot of changes recently on, federal grants, etc. Right? So how do you think the hospital organizations can actually justify the investment in AI-driven solution that may bring long-term benefits, but definitely in short-term, I agree with the question. They require a lot of capital training, and many senior level will be like, I just want to, do my job. I just want to, make sure the system don't break down. Why should we invest another $1 million on the new fancy AI tools? So I think this is a great question, and I would love to hear everyone's thought.
Maybe I can jump in and have a quick answer to this. Again, it touches upon the value creation part of it. If we can justify that the AI solutions that we'll roll out can enhance the healthcare professionals' ability to make faster, more accurate decisions, ability to reduce administrative workload so that they can focus on critical cases, And if it enables the more personalized treatments, yes, you are creating tangible business value. So definitely this is most important, that they see the value out of it. Also, the AI literacy program, we already talked a little about literacy programs. Some senior professionals which may not be tech savvy, but definitely we have to educate them a kind of basic 101 on AI, their strength, their limitations, and most importantly, how it can be leveraged into their day-to-day work, right? And they should also be well trained to spot mistakes and biases. Human in the loop is very important. Yes, AI can definitely assist them in terms of the decision making, but ultimately they should be taking the decision. So it's very important for them. It's a human in the loop is very important. I can, this is all I would say, and please jump in, but this just came to my mind. Yeah.
Thank you.
I can also jump in here, and I actually would love to flip the question back to you, Dr. Shi, because it seems like you've been able to be involved in programs that required, I'm sure, some capital investments. It is true that things will change based on the macro environment. And I mean, ultimately, these healthcare institutions are businesses. They're going to look at the bottom line. I do think that there has been a change, again, pre-ChatGPT, post-ChatGPT. Pre-ChatGPT, I don't think hospitals typically invested that much into AI. I think for them, it was kind of in that innovation bucket, which is one of those things you do if you have extra money. But it wasn't really, I don't think anyone really thought about it as solving real problems that, that immediately impact your operations. That is different now. I do think that if you talk to most healthcare executives, it's going to be one of the categories they have to focus on. So I think it would be unlikely that you speak to a healthcare leader who's going to say we're not going to prioritize investing in AI, even if they need to do some cost-cutting measures. I think it's just seen it's kind of like back then everyone had to invest in the cloud. It's now seen as a core technology. I think the other way to frame investments is not necessarily investing in AI, but investing in programs that impact your business model that might have AI in it. So for example, the program that you were describing, which I'd love to hear more about, it's not an AI project per se, I would guess. It's a project to increase access to, right, like maybe for using virtual or whatever it is. I mean, it's just a new care model that maybe strategically your organization wants to invest in. I mean, that's a very different value proposition that it really has nothing to do with AI, but it's very possible, and I would argue almost critical for you to have a strategy for leveraging predictive modeling and generative AI, whatever it is, to make these programs possible. I mean, I would argue to have a digital, virtual nursing program, you probably need some AI to make it work well. And I think that's another way to get your programs funded. But I'm curious, Dr. Shi, if you have, other thoughts here.
Thank you. So indeed, we have been facing different reaction when you talk to different kind of leaders. So I would say you can think about those more sort of early adopters of some of this technology. There tend to be the leaders, healthcare leaders who are more acceptive or to all this kind of new technology. There are definitely ones we talk to that probably struggle with a lot of their day-to-day work, and especially in smaller rural hospitals. We talked to some CEO there. They're like, we can't even afford Epic. If you talk to bigger hospital system, everyone is by default having Epic installed in their system. But if you talk to some of this smaller rural hospital, they'll be like, no, Epic doesn't even talk to us unless we get another 10 rural hospitals together to purchase Epic together. So what I've seen is like there is a huge now like a gap in all this AI adoption. I guess this also relates to one of the posted question. How can we make sure the AI also benefit hospitals in underserved and the remote community? I don't think I have an answer for now, but I think this is something that a lot of us researcher innovators should probably think about. We have this huge gap in AI literacy. How can we make sure people understand, we're not replacing their job, right? We're actually trying to help them do the jobs better, improving the system efficiency, and also like increase the access to care. I mean, so I agree, Dr. Lee, before GPT, like a lot of leaders don't really think about AI. Now, after GPT, at least they heard about Gen AI, it's easy to talk to them. But from my perspective, I also need to often question myself, are this leader thinking about invest this as a fancy sort of a new toy to say, oh, our institution is doing something AI? Or are they actually gonna put this tool in use for longer term and caring about people in their system that really needs to be cared? Yeah. So I guess Dr. Ma, do you have anything you want to add to this?
Yeah, I do agree. So human in the loop is very important. We need to tell people we are not replacing their job. We just want to accelerate, you know, the job to make it more efficient. So humans are still there, but machines can help you like do your job better and faster. For example, in my in the Stony Brook Hospital, recently I heard that so they are talking with some commercial companies about automatic medical coding, which can help them to do better billing. So because generally when you get some medical reports or discharge summaries, you need to like submit the medical codes to the insurance company, and they have you know, a team of human coders to do that job. But it's very slow and maybe not so accurate. So there are some commercial tools to help them like automatically extract the medical codes. And they are actually actively looking for such tools to help them do their jobs better. And I think that's a very good example. They don't worry these kind of tools will, you know, replace them. They are just trying to utilize like better tools to do a better job. Yeah.
So again, I guess this covers a bunch of questions we have discussed. How do you make sure the user trust that you're not doing anything harmful for the patients? You're actually helping them to do the job better instead of giving, you know, a bunch of, you know, nonsense recommendation. Then I think a lot of the user like would treat this AI tool more like a burden instead of like help. So I think this is something all of us should, you know, as a community should probably look into this, you know, furthermore. I guess these are all the questions, most of the questions we have seen. And I want to pose one last question, since we have a nice mix between industry and academia speakers. So what collaborative models between public and the private sector do you think are most effective in scaling digital health innovation from lab prototypes to large-scale implementation? So I guess Dr. Lee, seems like you run a big lab. Have you thought about converting some of the prototypes actually in usage? Yeah. In large scale, like implementation. Yeah.
Yeah, it's not a big lab, and the lab is more for prototyping within a health system, and rather than necessarily with the express goal of creating new technologies to spin into companies. What we do is we do these co-development partnerships sometimes with earlier stage companies for the purposes of, in our case, the value is we get to experiment with a capability, de-risk it for our health system, because often health systems spend a lot of money and time looking at a vendor only to find out that it's not actually solving the problem that we need to solve, and that's a waste of time and resources for everyone. We also have noticed from building our own applications that we deploy and test within our physicians that we actually do have quite a bit of expertise in that implementation layer, that user experience layer, especially given that in a large health system, there's such a diversity of use cases that it's almost impossible, I think, for any one vendor to capture. So we do have that expertise. So I think as we think of partnerships, combining that expertise on the implementation, the user experience layer, I think we have a clinical cabinet of early adopters who come to us with all sorts of ideas. We often will show them an application that we've built, or maybe something that an application that someone else has built. And you'd be surprised, like people are very creative and saying, oh, this actually is very useful for this use case that we never would have thought of. So I think that layer is very useful. On the other hand, we can't build, and nor do we want to build all the technologies. Technology is, we understand that it can't all come from our lab. We certainly don't want that to happen. We'd like to partner with others, companies that have spent much more money and time building probably better technology. And then I think that that's often a good starting point for thinking about partnerships in a win-win manner. So that's one way to do it. I mean, there are many other ways that academic medical centers partner with industry. Sponsored research is a very common one. But yeah, I think it really depends on maybe just going back to first principles. What are you bringing to the table? Like, what are we good at? I think as a health system, I think we often bring not just an implementation site, which is, I think, the most obvious asset, but also the expertise in the how, the what, around the experience. And then I think, we think about others. And I do apologize, I have to actually run to another meeting. So thank you so much for inviting me. And I really enjoyed speaking to all of you.
Okay, no problem. So, Dr. Ma, do you have anything you want to add to this collaboration between industry and academia?
That's not the best question for me. But actually, I came from industry. So before I joined Stony Brook, I was a researcher in IBM. So I know a little bit about the business aspect. But IBM healthcare department is not a very successful one. So yeah. But anyway, I think it's like a cycle. So from the industry to academia, first the academia side, we need to know what's the real needs of the industry, what's the real needs of the hospital, so we can find a better research question, and then we can find a better solution. But then from academia to industry, that's even more difficult. I know there are some small business foundations which can encourage academia labs to translate their prototypes to some product, but I know it's very difficult. So yeah, I think that needs some support from the bigger environment, from the government, from your institute, and also maybe from your own inspiration. So yeah, you want to do real products, you want to apply your technology to a real world. Yeah.
Sounds great. So Mithan, how's your perspective?
Yeah, absolutely. I mean, look, I'll go back to, at one point you made a comment on the undeserved communities, that how we can make sure that we can help achieve their access to the affordable care, and that's very important. This is where I believe there's a great role public-private partnership can play, and definitely it is that partnership will be needed or should happen to develop or co-develop AI-enabled digital solutions, which can be scaled and targeted at undeserved communities. So if you look at the developing countries or the undeserved communities, it comes down to the accessibility and affordability of quality healthcare. This is pretty natural, right? We have disruption such as telehealth. Is there telehealth solutions which has been disrupted, which can be leveraged to enable remote consultations with the doctors? But cost is also a very important factor. Many people don't have insurance. Many people avoid hospitals due to high costs. Now, if we can build let's say medical app or an AI-enabled chatbot, which can provide you instant free basic medical guidance and help patients decide if they need any urgent care, or deploy AI via SMS. Many undeserved communities, they might not have the proper bandwidth or the internet connections, maybe but SMS or some voice assistants. But this is when I see a larger role that the government and the private partnership are needed to make sure that we can help and scale the solutions so that it can reach to the undeserved communities. So this is where I see. Yeah.
Awesome. So I think we're covering all the questions, and seems to finish all the ones from the chat. So I guess we can probably wrap up this conversation soon. So before we close the session, wanna see if any of us wanna say a little bit more as a concluding remark.
Yeah, it's just a great discussion, and nice talking to all of you.
Okay, same here. So hopefully we can keep the conversation, open, since we all know each other now, and hopefully we can discuss more and maybe meet in person at some conferences or workshops later. Okay, and for anyone who's a live audience, also encourage you to, if you have more follow-up question you want to ask us, please feel free to, send us an email. You can probably find all of our emails or profiles online. So with that, I will conclude this session. Thank you all for